good to see some familiar faces in the crowd. And I've got some patients, fortunately, here that are very learned as far as it comes to prostate cancer. Can probably give this lecture for me. So I think they know what they're talking about, or I'm not talking about. Anyway, some of you probably already have or know us. My experience, I actually gave my first talk here about 11 years ago. And it was a wonderful experience. I got to see some of my patients, but also meet some of the other patients in the practice and some new folks that had come in that were just interested either for themselves or for family members and just want to learn. But anyway, my plan tonight is to have a kind of general overview of prostate cancer. There's been a few significant changes that have occurred since I last gave this lecture a couple of years ago. And so I've updated some of the information here to include that. So we're kind of go over things in a general manner. And, because one of the, as you'll learn and see, some of the challenges with prostate cancer, particularly more advanced prostate cancer, is there's not a clear-cut pathway. There's a lot of different factors that come in to how you manage men with prostate cancer. So we'll go over that. We'll touch on that. So first things first, I think it's really important that for those that don't have any experience with or I've learned anything about the prostate and prostate cancer, it's kind of just defines things. So we'll go over what the prostate is, what it does. We'll talk about prostate cancer in terms of how it affects people, in terms of how do we identify it, how do we grade it, how do we stage it. And then we'll also talk about prostate cancer as far as how we treat it in terms of, is it confined to the prostate or is it going elsewhere? And then from there, I'll be able to answer some questions from anybody in the audience. Okay. So the prostate cancer, or prostate gland, I should say. My wife, her roommate from college was an English major, and she said to me one time, I hear about all these problems that men have with their prostate. How come us women don't have problems with our prostate? And I said, oh, bless your heart, you're an English major. So the prostate is a sex gland for the men, and it sits at the base of the bladder, which is here. This is actually a male pelvis in cross section. So in the back here, you can see that's the colon which runs down into the rectum. And there's the bladder, and the prostate's in red. Right behind the prostate is this little gland here called the seminal vesicles. And this is supposed to represent the sphincter muscle right down here. You can see this is why, for those of you that have been screened for the prostate and prostate cancer, why we do a rectal vent, and you can feel it right here. This space between the rectal wall and the prostate is only a couple millimeters. So if there's any lumps or bumps, you can easily feel it. The prostate, for us men, has one role only, is to help liquefy your semen so conception can occur. So once you're done having your children, it does nothing good for you. It either gets big enough so that it starts to cause urinary problems, or it grows a prostate cancer. So it really doesn't help much after you've had your children. And so this gland is like a donut or bagel, based on your preference, and it wraps around the urethra. And so as it gets bigger, because from the day you're born to the day you die, for all men, the prostate gets bigger, it actually starts to encroach onto the urethra. And that's why men start to develop urinary symptoms. Typically in their 40s or 50s is when it may start, and it can progress and get worse and worse. And it's just because that prostate gets tighter and tighter on the urethra, which goes right through the middle of it. So that's why a lot of men will have problems with NCS for just benign disease, not even cancer. So, but what happens when you get cancer? Well, cancer, and in the prostate in particular, tends to be multifocal. You can actually get different areas within the prostate where you get some abnormal cells that grow, and they grow unchecked. So they're like a bad neighbor that don't recognize your boundaries. They just grow uncontrolled and don't recognize the normal signals to stop growing. So it begins in the prostate gland, and it can potentially spread locally. And in this instance here, you can see it's starting to spread into what's called the bladder neck. You can spread actually into the wall of the urethra and into adjacent tissues, or it can leapfrog through your lymphatic system into the lymph nodes of the pelvis, and even to distant areas like your liver. And that would be another area that it likes to go to. So there's a number of different areas you can go to, including the bones. So prostate cancer, I would say the top two sites where it likes to go is either the lymph nodes in the pelvis or the bones, particularly in the lumbar spine, your lower spine. So those are areas that can be affected. Most of prostate cancer that we identify is organ confined. So that means patients have a lot of good options and actually have a very good chance of a cure. That's on cue, the ER is calling me. Okay. So when you catch the prostate cancer confined to the prostate, you have the most options available. That's your highest likelihood of being able to develop a cure. So just like any other disease state, you want to catch things early. And so for that reason, it's very important to assess men for risk factors for it. The biggest risk factors are family history. So if you have a first-degree relative, either your father or brothers that have it, that affects your risk. And if you're African American, and what the way it affects your risk is that you're more likely to develop it at an earlier age, and it's more likely to be more aggressive. So these are the type of guys you definitely want to catch, and you want to catch early. So we factor that into our screening and for all men, and that's another thing that we look at too, is whether or not men have symptoms. Now, prostate cancer typically, as I just shared with you, is organ confined. So for most men, they actually don't have symptoms. But it's important not to completely disregard symptomology. It's not always just an enlarged prostate. So anytime I see a guy that comes in and he's got a lot of urinary symptoms like you're seeing here, either weak flow or urgency and frequency of burning, or maybe even have blood when they pee or when they ejaculate, I always make sure I get a good rectal exam and a PSA blood test on them as well, because we need to make sure that this isn't an odd presentation of prostate cancer. But the overwhelming majority of prostate cancer is actually asymptomatic. And it's not necessarily just something that happens in older men too. We detect it in younger men too. So you'll see in the next slide, or sorry, the slide after this, what we do in terms of the age ranges for screening. So as you've already heard, early detection is key. So it's important that men, particularly higher risk men, get in to get screened with a PSA and a rectal exam to get checked out. I'd already alluded to the fact that in the mid-1980s, there was a very important event that occurred. PSA was identified, and this is a protein test, and it's a protein that's made by the prostate only. And once this was identified in the mid-1980s, by the 90s, we had already seen a significant change in the type of disease we were seeing. Prior to PSA, we didn't have a lot of testing that we could do to screen for prostate cancer other than a rectal exam. And there was one other test called a prostate acid phosphatase, and that wasn't a great test. And so a lot of men, when they presented, they actually presented with very advanced disease. Once PSA came around, we now were picking up men a lot earlier when the cancer was confined to the prostate, so it gave them much better options and outcomes. Okay. And frankly, a lot of men can actually contribute to their health and wellness based on that kind of screening. So we've touched on this other already, and PSA, the single simple blood test. There's a lot of things that could affect a man's PSA, so I always like to remind men when I'm seeing them in the office. A pretty common consult that I get in the office is elevated PSA. Well, PSA, as you see it described, is specific to the prostate, but it's not specific to cancer. So there's a lot of other things that can affect a man's PSA. I already shared with you, as men get older, the prostates get larger. So as they get larger, they make more PSA. So benign growth of the prostate will make your PSA grow. Infection, if you have a urinary tract infection or prostatitis, that can make you go up. Inflammation can make you go up. If the doctor did a vigorous rectal exam, or you had a heart valve movement, or had even ejaculated shortly beforehand, that can make your PSA go up, and cancer. Okay, so it's not a test that's specific just for the prostate and prostate cancer. It is just specific for the prostate, though, and that's one of the challenges that we have when we see an elevated PSA test. But in the absence of a better test, we're still tied to it. And something that we still continue to do, but is not as sensitive as the PSA, is the digital rectal exam. That's everybody's favorite test. I was supposed to be laughing. So no, it's not. I tell my patients it's a rite of passage. You get to that age where you need the rectal exam. The rectal exam we got a lot easier than the exam that women have to get. So I tell them to stop complaining. But the two of those tests in particular are helpful for screening. There are rare instances, particularly with actually, unfortunately, very aggressive prostate cancers where the PSA doesn't change much, but you may feel an abnormal rectal exam. So that's the reason why we can still continue to do the rectal exam. Now, there was a couple of years ago, there was this task force that Medicare has, is the United States Preventative Task Force. And it's a committee within CMS, which is Medicare, that was tasked with looking at all the different screening tests that people get. Colonoscopies, mammograms, and PSA. And so they went through and they looked at all the literature about PSA and PSA screening, and they gave it a D. Okay, so they gave it a very poor grade. That created a lot of confusion, and because a lot of people, particularly even a lot of primary care doctors, said, "Oh, it's a bad test. Let's stop doing it." That's actually not the message that was supposed to have been delivered. It's a test that actually has its limitations, as I already shared with you. The best screening test is a yes/no test. You have cancer, you don't. And as you've already learned, PSA is affected by a lot of different things, not just cancer. So until we get a better test, it's still a very important test to use. And the way we're able to evaluate it, which you'll learn about a little further here, still makes it a very valuable test, particularly in men that have been diagnosed with prostate cancer. So it's very helpful in that end. So I alluded to this earlier. Who do you screen? Well, overall, I've got this table up here, but the biggest thing and the biggest takeaway here is this. You want to see prostate cancer in the overwhelming subtypes of prostate cancer we see generally tend to be slow growing. So it's not, there's certain types of cancers that unfortunately are very aggressive and have a very poor prognosis, like pancreatic cancer and so forth, where when you're talking about survivability, you're talking about 6 months survivability. Prostate cancer is not typically like that. So we look to see, really, we want to make sure we're screening men that have at least a 10 or 15-year survival potentially. We also factor in the family history and whether or not they're African American, and that affects when we start screening. I start screening pretty much anyone that's got a strong family history or they're African American by age 40, and pretty much everybody by age 50 gets screened. And that's as I mentioned earlier, the PSA and the rectal exam. Central Coast, we got a lot of people that take good care of themselves. So I don't think, when we talk longevity, the same rules necessarily apply around here as they do in some other parts of the country. So we tend to actually, and a lot of patients want to be screened into more advanced years. And you'll hear from them, yeah, everybody in my family lives to my mid-90s. So it's not the same as, what you may experience in some of the southern states. There was some recent articles that came out about life expectancy based on where you live. And there was a clear difference of about 20 years from certain states. So it has to do with a lot of different factors, socioeconomic, access to healthcare, nutrition, all that. So this number is kind of fluid. Really, you got to look at the individual's family history in terms of what does the typical family member live to and their overall health and how they're taking care of themselves. But if you identify, have a patient go through and they've got an abnormal PSA and or an abnormal rectal exam, then we need to take the next steps to figure it out. And that's when we proceed historically with a prostate biopsy, but more recently in the last 10 years, it's been pretty typical that we proceed with an MRI prior to the biopsy. Initially, the MRI technology really has improved significantly, such that in the last 10 years, it really is a helpful tool for us to identify areas that are abnormal, that in turn, well, sometimes we use the MRI as a trigger to say, okay, that area is a high risk area. Yeah, we definitely need to do the biopsy, particularly if we're on the fence for an individual. But regardless, it'll give us information about if you ultimately do find cancer there, does it look like it's spread through the walls of the prostate, into the seminal vesicles, and so on and so forth. So it gives us a lot of information. And nowadays, actually, it's become almost every insurance plan is covering it. We had a big issue with that a in the last 10 years getting coverage for it, but now it's become kind of standard of care. So it's a lot easier getting it covered. So once you get the biopsy, if it does come back positive, then you need to figure out what to do. They're going to give you a Gleason score, and that score goes from 1 to 10. If they find a cancer, they have to score it. 10 is the most aggressive number you can have. If you've got a high-grade prostate cancer, then unfortunately that also puts you at risk for having more advanced stage as well. So the staging is something that we do once we figure out the Gleason score, which we'll get that from the actual biopsy report. The staging will come from your clinical exam. Did you feel any lumps or bumps on the prostate? And potentially there's clinical staging and then there's pathologic staging. The clinical staging is if you've gotten imaging that identified, for instance, some enlarged lymph nodes or maybe metastases in the liver or something like that. Or frankly, if it was all negative. And then pathologic is tissue you've actually taken out. Okay, so if you did surgery on someone to remove the prostate and lymph nodes, you're going to get a pathologic stage. So, but that falls under this umbrella of TNM, tumor, node, metastases. And so this is actually the scoring system here that we use to assess where your prostate cancer is. So if it's stage T1, that's typically you found the cancer because someone had an elevated PSA, or someone had actually a procedure like a TURP because they have an enlarged prostate, and we incidentally found cancer on the specimen. Okay, but this is someone that had a normal PSA and had a normal rectal exam, but we had found this incidentally on specimen. Then there's stage 2, which is usually palpable disease. You can feel lumps or bumps on the patient, on their prostate. And 3, it actually is where it's starting to extend beyond the capsule of the prostate into some of the local tissues there, including the seminal vesicles, which I pointed out earlier. And then 4, if you feel a 4, it's really a fused prostate, and you're really not feeling the boundaries. It's really kind of fixed. Okay. Lymph nodes, you can't feel the lymph nodes, they're deep in the pelvis. So this would be something that you'd pick up through imaging, or if you did radical surgery and did the sampling of the lymph nodes. And metastases, you're going to pick those up with imaging. So once you get the grade and the stage, then you need to kind of assess what you're going to do for the patient. So, and that's done by really trying to assess how concerning their cancer is. Okay. So we have the NCCN, National Comprehensive Cancer Network, and the AUA, American Urologic Association guidelines. And these are data-driven guidelines that have been developed so that we're not just, when we see a patient in the office and identify prostate cancer, we're just not willy-nilly pulling things out. We're following guidelines, and these guidelines are based on how many cores of tissue had cancer in it. What Gleason score was it? What percent of the cores were involved? What was your PSA? So all this gets factored in, and then you can come out with a risk assessment for someone. For instance, for NCCN guidelines, based on what I just mentioned, you'll be able to tell a patient if they have a very low risk cancer, low risk, intermediate, or high risk cancer. And that'll help flavor your decisions about how you're going to direct patients. And the guidelines even have actually recommendations about what you should do for the individual based on what their grading is. Okay. Now, something that's come out in the last 10 to 15 years, actually probably more like 10 years, we have something to help us with that. So there's a lot of new technology coming out. We're learning more and more about the genetics of everything, including cancers. And so I've listed here 3 tests that we do. And these are tests that are run off of the biopsy specimens. And each one of them looks at a couple different genes here. And these genes, some of which, if you have them, it's a bad sign for the cancer. Some of which, if you don't have them, it's a good sign. But overall, what it's supposed to do is when you get, for instance, for NCCN guidelines, if I have a patient that had a biopsy done, and by NCCN guidelines, they're very low risk, I can get one of these tests, and these tests are going to say, okay, genetically, yeah, it looks like a very low risk cancer, or no, it actually looks like an intermediate risk cancer based on the cancer genes that they're finding in the individual cells. Okay. So This is one area where genetics is now part of our workup and evaluation for men with prostate cancer. And you'll see there's some later on in the talk for advanced prostate cancer. It's also playing a significant role. So I'd like to tell my patients too that, you know, one of the problems with prostate cancer is there's a lot of options. So sometimes that can make it a little confusing and challenging. You know, for instance, kidney cancer is usually a surgical option. Surgery. That's usually the best way to deal with it. But for the prostate, there's a number of different options that we have. And so that's something that you would go over with your urologist, of course. So this table is meant to represent kind of, at least, we break down prostate cancer into two different categories: localized or organ confined, and metastatic or advanced. Okay. So this part on this slide is just really going to focus on the organ confined disease. Okay. So this is disease that you identified is not gone beyond the walls of the prostate, and it's in the prostate only. So active surveillance. It is what it sounds like. We're not actually treating. We're going to watch it. Now, 20 years ago in this country, almost nobody was on active surveillance. That was almost heresy to suggest that someone has a cancer and you didn't treat them for it. What we're identifying, and actually a lot of our European counterparts have really kind of spearheaded it, is that there's a lot of prostate cancer that is very slow growing and actually may not need to be treated. There's a way to be able to watch men with prostate cancer if they have the right disease and they're the right patient, where you actually don't have to treat it. Now, you don't just say, okay, congratulations, I think you're candidate for active surveillance, and just send them on their way. There's protocols in place that we follow to make sure that, because we don't have a test that says, aha, you're 100% the right person for active surveillance. We're using all the data you've already heard about to help assess someone and identify them as candidates for that. So typically, for instance, the protocol I follow for most patients is that if a patient chooses to go with, and they're the right patient for it and chooses to go with active surveillance, in the first year, you get a PSA every 3 months. And then typically a year later, we will rebiopsy you. We're mainly trying to see that there frankly hasn't been a change in the cancer and or that there wasn't a sampling error. So, and then beyond that, if we're showing stability here, we can start to space it out even further. So there's going to be a role to repeat the biopsy, so on and so forth down the road. Surgery and radiation are the two other options that actually we have the most experience with as far as dealing with organ confined disease. Nowadays, the overwhelming majority of prostate cancer, when it's treated surgically, is done laparoscopically with the Da Vinci, which is from Intuitive Surgical. That's their robotic platform. That's how we do them. I probably do 99% of mine that way. There's rare instances where an individual may not be accounted for it just because they can't have a laparoscopy for various reasons. So it's usually something outside of the prostate cancer that actually makes them not accounted for it robotically. The open surgery is still done, but just not as often. We'll touch on the radiation a little bit more in a minute, but essentially with radiation, when all said and done, you get radiated, you still have a prostate left over, but what we're doing is we're literally kind of cooking the prostate with radiation therapy. There's a couple different types. Brachytherapy, where actually radioactive seeds are implanted into the prostate. That was a very common modality that we're using. But frankly, with some of the improvements in the external radiation therapy, the radiation therapists are not doing that as much anymore. They've switched to a lot more of the IMRT. There's proton therapy, CyberKnife, which are some other technologies. The latter two I just mentioned are not locally available, but there are some centers here in Southern California that really actually help develop the technology that's used worldwide, that are excellent resources that we use and refer patients to. And then there's two other treatments that we use for organ confined disease. I have hormone therapy here, but I'll share with you about that in a second. HIFU, high intensity focused ultrasound, and cryotherapy. HIFU is a type of ultrasound technology which literally cooks the prostate, and cryotherapy is where you freeze it. So these therapies are typically used for lower risk disease, and there's lower risk disease, and there are some centers that are actually doing clinical trials looking on focal therapy. Everything we've talked about so far is treating the whole prostate. And surgically, you're not really able to go in and just wedge out part of the prostate. There's a lot of anatomic considerations to go in there, and it's really not viable to do that. But with these therapies, you can actually go in and just freeze one part of the prostate or just treat one part of the prostate with HIFU. So there's some promising clinical trials coming out, but it's mainly in the low risk disease state. Now, there's obviously pros and cons with all these different options. The active surveillance, if you're so lucky to be able to continue on it, we usually follow patients out for, depending on their level of health. It's easy enough to get a PSA, so we usually continue following patients to the end. I tell them, the key to the name is active surveillance. Every time we get another data point, another PSA or another exam, we're actively assessing whether or not this is the right pathway for the patient. Surgery, it's usually an overnight stay in the hospital. It's done under a general anesthetic. After the surgery, you have a catheter in the penis that stays in for about a week. There's a little drain that comes out of the left side of your abdominal wall. That usually comes out before you leave the hospital. After that, there is a little bit of a recovery, of course, just like any surgery. And there's certain parts of your health that are affected with any of the interventions for prostate cancer. The urinary control and erections, and it has to do with where the prostate's situated. So the nerves that give a man the ability to have an erection are plastered on the back of the prostate. So those can be affected with any of these treatment modalities. The urinary sphincter, which controls your ability to hold your urine, is underneath and the base of the prostate. So that could be affected. So anybody that gets treated with surgery will certainly have a period of time of recovery where they're going to have some urinary leakage and have some erection problems. But we have things that can be done to address all these things if they don't ultimately get to where a patient wants them to be. Radiation, some of the potential side effects of that are a little different. And on the there's a couple different ways it's administered. And the longest it'll take is 40 sessions typically. And so about 2 months worth. But nowadays, there's actually some newer protocols that the radiotherapists are using. So they're able to give you more radiation in shorter bursts. And so they're able to cut that time down. The biggest side effects men get from radiation down there is that it will affect your urination. You'll have urgency and frequency. It can affect your nerves as well. It could also affect your bowels because everything gets affected with the radiation. So men could have some fecal urgency as well. Okay. But that's not that common these days, again, because of the technology. It's improved to the point where we don't see that as often. So when you have a bunch of different options, it's important to have some sense of how do they compare. I've already talked to you about the DD issue that you can have and the urinary control issue you can have. Well, how does it cure the cancer? We're talking about cancer. We're talking about cure. So that's the most critical thing here when we're talking about treatment options. And so you can see from this graph, and this is actually a Catan nomogram. Catan was a epidemiologist at Memorial Sloan Kettering who devised this nomogram about 20 years ago. And he essentially took all the patients from Memorial Sloan Kettering and kind of took all their information, kind of compiled it. And this is a representation of how men did with this. And so the biggest thing that we have the longest experience with is surgery and radiation, which is why this is on here. The hormone, which you saw on the last slide, or 2 slides ago here, hormone therapy doesn't play a big role for organ-confined disease with one exception. If a person has higher grade disease and are going to get radiation, we oftentimes will do it with hormone therapy as well. The reason for that is twofold. As you saw, the radiation sometimes takes 2 months to administer all of it. Well, we don't want to leave someone untreated, so we'll put them on some hormone therapy to help keep the prostate cancer at bay. And in addition to that, it actually will help sensitize the cancer cells to the radiation. So the radiation is potentially a better killer. Okay. So that's why this is on this slide as well. But as you would expect, if your cancer is all confined to your prostate, over time, in these instances here, you still have a prostate. So there's always the potential for residual disease having been left behind with other treatments and or just development of another prostate cancer. Whereas with surgery, it's out. It's all out, can't come back. So that's why the cure rates are always a little bit better for surgery versus the other treatment modalities. Now, this slide, kind of at this point, since pretty much everybody's doing prostate or the radical prostatectomies in a robotic manner, this is less of a point that needs to be made anymore. Because it's been well established that actually the cancer control is better, you get a quicker return to continence, you're able to do a little better nerve sparing, the margin status is better, there's definitely less blood loss, less pain medication that you need to take, because instead of having a bigger incision, it's a much smaller incision. So we do it in 5 incisions, or 5 little incisions. This is how it used to be done. I do mine now kind of straight across. So 5 little dots there. The belly button one we make a little bigger because that's where we take the prostate out of, as opposed to the old incision, which was the up and down incision. This is an example of the console, which is where I sit. Once I get the robot dock on the patient, take off my gloves and gown and go sit at the console and do my robotic prostate video game. I got a good score. So the way the robot actually helps, and actually, if you ever get the opportunity to see one, periodically the hospitals will bring one through for various kind of health fairs. It's pretty cool technology. When you have laparoscopy, so just to kind of define this, laparoscopy is when you're doing anything in the belly where you're not making a big incision, you're doing it through the small little incisions there. So when you're doing a laparoscopic procedure, that's what you're doing. So, but with typical laparoscopic equipment, you have a fixed arm. So you can move like this and like this. What you don't have is a wrist. Okay. The robot gives us an endo wrist. So that makes it a hell of a lot easier trying to sew. Because imagine trying to sew like this. It's pretty awkward. So the robot also, the software is such that it actually translates your movement. If you had a bad tremor, it gets rid of your tremor. So there's a lot of other things that it does to help it. You're working under magnification. You're actually seeing the nerves, the bundles. So you can see the apex, whereas there's certain parts of the open operation where you're doing it all by feel. Now that's one knock against robotics is that you don't feel. But you do get some tactile feedback from the actual robot. When you're hitting against something hard, you feel it in the hand controls. It kind of gives you some feedback. So, but it's a pretty quick recovery for these patients as far as the incisions and so forth. They don't need a lot of pain medication. So I already alluded to this in terms of how do you do, like as far as comparing the outcomes. Well, open surgery, the positive margin rate is significantly higher versus the Da Vinci. Now, positive margin meaning when you took the prostate out, you had cancer on the edge. Okay. And the Da Vinci, there's 2 parts of the prostate where you're more likely to get a positive margin of the apex or the base. The apex is down low, and that's hard to see. And so when you're doing that part of the surgery open, it's all by feel. So we're going to dissect it out. Certain parts that are all by feel. Whereas with the Da Vinci, I'm seeing the whole thing through. So I can see exactly everything where I'm cutting, where I'm dividing, where I'm putting stitches and all that. I'm seeing it. So that would explain why we have a better margin status with the robotics platform. And then the second thing I talk to my patients about, the first is cancer control. The second thing is continence. Every guy that gets their prostate removed has leakage afterwards. Hopefully, it improves significantly in the first month or 2. And we see that there's typically a faster return to continence with the robotic in the short and long term. And again, you just get a much better look at the anatomy. Sexual function. Now, this data is a little bit of a challenge because you've got plenty of patients that come in with all different levels of sexual function. So if a guy's got poor sexual function going in, guess what? It's going to be poor after. This surgery does nothing, whether you do an open or robotically, it does nothing to help with erections. So that part goes without saying. And the other challenging thing that I talk to my patients about too is the disease state plays a significant role in how aggressive we're going to be at sparing your nerves. If you have a high volume, high grade prostate cancer, we may not be that aggressive sparing the nerves. And in fact, sometimes we actually will sacrifice the nerves. The reason for that is, as you saw in the first slide, we want negative margins. And if you've got a big aggressive cancer, the cancer may be abutting the capsules of the prostate on either side. And so where the nerves are is one of the few areas where there's a little extra tissue that you could potentially take in an effort to try to give you a negative margin. So first and foremost, when you're doing an operation for cancer, that's got to be your primary goal, getting the person cured. We've got other things that we can do to help with the erections. We've got, everyone knows about Viagra and Cialis. There's injections, there's urethral suppositories, there's penile prostheses. So we got a lot of things. We'll get you an erection. We'll get you there. But first and foremost, we got to make sure we get you cured. So in the radiation world, IMRT, this is how the bulk of prostate cancer is treated. This is external radiation therapy. Okay. And like I said, there's newer protocols. It's not as common that guys have to go in for the 40 treatments. They're able to manipulate the technology such that they're able to give you higher dosage with less frequent treatments. Proton beam therapy, that's down at Loma Linda. Loma Linda is one of the pioneers with this technology. So we have patients that, if they're interested in appropriate candidates, we get them to Loma Linda. CyberKnife is another robotic kind of radiation that's administered. With the proton beam therapy, where it is, most patients, if they're not going to go with IMRT locally, they're usually going for proton therapy. And as I shared with you already, brachytherapy is just not being done as often. Because brachytherapy has to be done actually under a general anesthesia. So it's a procedure in the OR where we put the radioactive seeds in. And then depending on which isotope you get put in you yourself are actually radioactive for about 6 weeks. So you got to kind of, the rule of thumb is 6 feet for 6 weeks from kids, or you sleep in a different room than from your partner, just because they don't need to get radiated, of course. So I think that's one of the reasons why a lot of people have kind of steered away from brachytherapy in more recent years, as we learn more and more about the long-term disadvantages of radiation. Now, for any of these therapies, though, as part of the setup for it, you may be asked to get gold seeds. And so this is exactly what it sounds like. We put 3 little gold seeds in the prostate. Yes, you're worth more after this. Not a lot more, but worth a little more. But those gold seeds actually help with the targeting so that they can administer the radiation safer and easier. Now, this other product here, there's 2 of them, Spacer and Barrigel. I alluded to earlier that some of the side effects or potential problems when guys get radiation is that they can affect your rectal wall. So this is a product which is literally a gel that we inject between the prostate and the rectal wall. And what it does is it kind of pushes the rectal wall away from the prostate. Now with radiation, even millimeters makes a big difference. The way that radiation works, particularly the type of radiation you're getting from prostate cancer, the further you can get your tissues away that you don't want to radiate from the source or the target, the less harm is done to the tissues. So even though you're just displacing the rectal wall, in some instances just by a centimeter or 2, that makes a significant difference in terms of how much radiation that rectal wall is getting, and therefore has a significant difference in terms of what potential side effects you may have from it. However, I got to be honest, I'm not a huge fan because, frankly, doing these procedures, for those of us in my group, the jury's out on it a little bit. We're not sure it's helping as much as the data says that it does. So we're not using that as much. And even the local radiation therapists are not as enamored by it as well. Because one of the potential downsides to it is if the gel is injected and is not exactly where you want it, that may delay when you go to get radiation. So that's the reason why, or one of the reasons why we're not using it as much. it's kind of one of those situations where you're fixing a problem that may not really be there. So now we touched on this earlier, and just to kind of give a little cartoon to it, this little cartoon up here represents high intensity focused ultrasound. And this little area here, that's supposed to represent the rectal wall, the rectum. And this is a little ultrasound probe that goes in the rectum. This procedure is done under general anesthesia, so the patient's asleep and it's in the operating room. And this little guy here is supposed to be your prostate, and there's the prostate cancer. And so with this technology, you're able to go in. This ultrasound head has two heads to it. One of it is a diagnostic, so just like the ultrasound we use to do the biopsy, it also has a therapeutic head in it too, which generates the high frequency ultrasound, which literally kind of cooks the prostate tissue. But it's actually the technology is such that you can really pinpoint the areas that you want to treat. Because what will happen is once you get it all set up, you actually will have the whole prostate in real time right there in front of you, and you can pick out exactly where you want it to treat. And then you hit go, and the thing does it. So that'll allow you to kind of, if you're doing a focal therapy, be able to say, well, we just want to treat the right side or the left side. It's very easy to identify that and then just treat those areas. Now, what's the benefit of that? Well, the benefit is you'll be less likely to have problems like we already talked about as far as affecting your urinary control, or even affecting your risk for developing scar tissue in here, or your risk for affecting your sexual function too. So that's a significant pro. Cryotherapy, this is not done as much. This is done more in a salvage situation, whereas if someone had opted initially to get radiation therapy and then had a recurrence, and if they had a recurrence to the prostate and there was no evidence that it had not gone anywhere else, then you could potentially get cryotherapy. You could get HIFU too. One of the reasons for that is that, going in to do surgery after someone's been radiated is a really challenging operation. And it has to do with the fact that the radiation, just think about it, it's strong enough to kill cancer cells. Well, what does it do to your normal tissue? It makes it very friable, or the whole area just kind of fixed. So there's no normal planes that are in there. So dissecting out the tissues is so much harder. There's a higher risk of having side effects or complications related to that. So that's why it's really important that you pick the right treatment right out of the gate. Okay. And as I already alluded to, there is ongoing clinical trials for both these technologies because they both lend themselves to be able to do just a partial treatment. So that's all organ-confined disease. So if someone's identified to have organ-confined disease, after you get treated, we don't just say goodbye. There's always room for follow-up here. The PSA actually becomes a very useful test after someone's been treated. Because remember, prostate is the only gland and the only tissue that makes PSA. So if you removed it all, or if you treated it and the PSA became undetectable, it should stay there. So it's actually a very useful test, at least initially, for people that have already been treated for prostate cancer, as far as trying to follow them out and make sure they're staying cancer-free. If there's ever any issues with the PSA, that's when we get imaging going and possibly have to rebiopsy. So that leads to the next question. What happens if your prostate, you did get treated already, and your prostate cancer returned, or when you originally presented, the cancer was already out of the prostate? So this area, there's not a clear-cut pathway that everybody takes. We have, as there's some nuances to it. So for this part of the conversation, I'm going to cover some of the different treatment modalities that we have. And it's pretty exciting because you'll see why in a second. Okay. So if the cancer comes back and you've only had the treatments that you already talked or heard about, it hasn't seen necessarily, unless you had the hormone therapy when you got radiation, is considered typically to be castrate sensitive, and you haven't been on any hormone therapy. The hormone therapy that we use is designed to knock out a man's testosterone. Your testosterone stimulates the prostate and stimulates prostate cancer. So it is a very helpful tool, knocking out a man's testosterone in order to help with the treatment of the disease. Historically, this usually meant that before we had medications and things like that, men would get their testicles from them. 95% of all the testosterone that a man has comes from his testicles. About 5% of it comes from the adrenal glands. Those we would have removed because they actually have, the adrenal glands have a number of other functions, and you wouldn't want to be without that. So castrate-sensitive prostate cancer versus resistant, and it's exactly as it says. Unfortunately, prostate cancer for men when they've been put on hormone therapy, pretty much for everyone, it typically is at least sensitive in the beginning, but if it ever becomes resistant, historically, that was not good. And it really had to do with the fact that and this goes back to probably about 2002. So before 2002, if you were castrate resistant, you had a life expectancy typically of about 2 years because we didn't have anything else. We had nothing else that was really effective at that time. So there's been a robust collection of treatment modalities that have come out, and there's newer things coming out as we speak. So in this case, when we see men that have gone from castrate sensitive to resistant, the PSA is not as good of a test. Okay, so that's when we have to start to rely on imaging to help us out. So CT scans and bone scans, they've been the hallmark of therapy, or I should say staging, for prostate cancer for decades, until about 15 years ago. Then we had a sodium fluoride scan, which was about 50% more sensitive for finding prostate cancer than a bone scan. A bone scan, though, does not discriminate. What it does is it looks and finds areas of abnormal activity and the lights up. But the scan can't tell you if that's cancer, can't tell you if it's infection or inflammation. So it's a non-specific finding. Then one of the first kind of scans that came out that actually helped us identify prostate cancer when it metastasized was the Oxman scan. And more recently, the PSMA PET scan. This is a prostate or a protein that's made on the membrane of the prostate cancer cells only. And so it's tagged to only pick up PSMA. So this actually helps you find when something lights up in the prostate, on the scan, it's finding prostate cancer. So it's a more sensitive test, and this is something we've had available for the last 2 years or so. So we're doing a lot of PSMA scans for various indications. So in the individual that was seeing a rising PSA, sometimes you have to get a biopsy. But we don't always do that now that we have a scan such as the PSMA scan. Sometimes that's enough evidence to tell us that, okay, the cancer is back, and we don't necessarily need to do the biopsy in all settings, with some exception. This also, I already touched on some genetic testing that we do for prostate cancer early on when we're trying to figure out how to treat a guy. Well, this is some newer testing that's being done, and this is not just in the prostate cancer world, this is across the board, because what we're doing in medicine and in oncology in particular, we're going away from we're going to treat all of you, meaning your whole body. We want more precision treatment. Why do we need to beat up all the good cells and good tissues? We want to be able to just target the disease, right? So up until the last couple of years, most of the treatments that we had were designed to just treat the whole body if there's cancer there or not. Okay, so there's a lot of unnecessary toxicity that you can experience because of that. So we've identified a set of genes, and this is just kind of right out of the gate. And this is something that's expanding. Every couple of months there's more information coming out. So you may have heard of the BRCA genes. BRCA genes have early on were implicated in breast cancer. Breast cancer really has kind of led the charge in a lot of this. There's a lot of funding for it. So that's one of the reasons why. But breast cancer it's a sex organ, your breast. Okay. So BRCA genes can affect men, and what a lot of men don't realize too is that 5% of all breast cancer is in men. So just because you're male doesn't mean you're not vulnerable to prostate or to breast cancer. But the BRCA genes have been implicated with breast, ovarian, and prostate cancer, just to name a few. And these are some other less common genes that if these are identified in there, they will have an impact on you as far as prostate cancer as well. So this is just to name a few of the companies that we're using to actually do this kind of testing. And so this testing does help. Germline testing is important because that'll let you know, what am I passing on to my kids? Okay. Somatic testing is your actual cells, and so the somatic testing will help direct us in some of this kind of very precision-based kind of treatment, which you'll see in a few slides. So this is exciting stuff that's really just kind of exploding right now in all fields, but particularly in prostate cancer. And when I say all fields, I'm talking oncologic fields. So taking a step back here, we talked about hormone therapy. I told you in the old days, a man had to get a bone testes removed. Well, we almost never do that anymore since these products have come out. And these are kind of, I gave some examples of the different ones that we're using nowadays. GnRH. So your testosterone is, like I shared with you, comes from the testicles for the most part, 95% of it. Well, the testicles just don't produce it. It comes from the pituitary gland, sends some signals that make their way down to the testicles for you to produce your testosterone. Stimulate your pituitary gland in such a way so that the pituitary thinks that there's actually an abundance of testosterone, and so it shuts it down. So this was the first way we were really able to kind of have the most effective kind of way to knock out a man's testosterone levels that didn't require an orchiectomy. Then a newer product that came out, the antagonist, which actually block that, so it's not going to produce it. That actually will drop your testosterone a little faster than these products, but after the first 2 weeks, they're pretty much equal. We use a lot of orgovics, these are all injections. We use a lot of orgovics now for men that are just going to be on short-acting hormone ablation therapy, because when you go on hormone ablation therapy, you get all this. It affects your energy, your sex drive. You get hot flashes, depression. Your muscle mass will decrease. You'll get potentially fatter. So all those things can be really kind of debilitating for some men. So whenever a guy is done with it, they want off of it. They want to get the testosterone back. Well, the orgovics has been shown actually to allow men to get their testosterone back naturally the fastest out of all these different agents. So these are the first line kind of therapies nowadays, and this has changed in the last 5 years. These other receptors, these are all pills. This is the second generation of androgen therapy. I just listed a few of them. Initially, these were used after you became hormone resistant, but we've identified there's been a lot of clinical trials that have shown that actually, if you have a high-risk disease right out of the gate, you're better off being on combination therapy. That actually improves your survivability and your recurrence-free survivability as well. So again, this is something it's in motion and it's constantly changing. But hormone ablation therapy typically has its role with metastatic disease. But as I shared with you before, at least these products are used in the short term when guys are getting radiation if they have higher risk disease. So again, I mentioned before, 2002, we didn't have much to do when you were castrate resistant. That's when a very important paper came out of my alma mater, Columbia Presbyterian in New York, where they identified this family of chemotherapeutics, Taxotere, the taxanes. Those have actually been very helpful and are very, they play a significant role in addressing widely metastatic prostate cancer, regardless of whether it's to the bones or to the soft tissues. PARP inhibitors. Now, these days, depending on what magazines you read or what commercials you see, you're going to see ads for PARP inhibitors. And they're being used in a lot of different cancers. Okay? Lung, kidney, prostate, they're used in some breast. And so what this whole category of drug is doing is they're taking advantage of the fact that when you get a cancer, it's because the DNA of that cell was damaged. Okay, and so what these PARP proteins do is they're supposed to fix that DNA, both in healthy and cancer cells. We don't want it to do it in the cancer cells; let them die. So the PARP inhibitors are supposed to help promote that. Okay, so by doing that, it's inducing apoptosis, which is the cell's natural desire to die if it's not normal. Okay, so it's supposed to help promote that. And what I listed down here at the bottom is a couple of more commonly used PARP inhibitors. Now, in order to be able to be on these, though, it's been identified that you need certain genes, like these HRR genes. So if you don't have these, the PARP inhibitors are not as effective. So it's a very specific subset of patients, at least with the knowledge that we have now, that are going to be candidates for the PARP inhibitors. So you actually, in order to get a PARP inhibitor for your prostate cancer, you need to have one of these tests done to see if you have these genes, and then it'll match you up with the appropriate PARP inhibitor. Now we're talking, this is also in the range of this kind of targeted therapy. So Provenge is something that's been around for about 10, 15 years. And what this is you essentially will take a patient's blood, they take it off, they identify and they spin out the T cells, which are part of your immune system. And then they'll manipulate those T cells so that they now will become prostate cancer killers, and then transfuse that blood back into you. So you do that 3 different times over the span of a month. And this has been, once you get to this kind of refractory or recurrent prostate cancer, that's when you're a candidate for this. Okay. There's Zofigo, which is, this is now a targeted kind of therapy, but this is only really if you have prostate cancer in your bones. If you don't, if you have it in your soft tissue, this is not going to work. It doesn't affect the, for some reason, doesn't affect the soft tissue the same way it affects the bone. It has to do with the isotope that's administered. So you'll get, what you do is you get an injection of this radium, which is a radioactive isotope, into your body. And it's going to go, and it has an affinity to the bone metastases. So it really will just go after the bone mets. Okay. Now, the most exciting thing that's come along, which a lot of us are really excited about, is the lutetium. Okay. This is really where a lot of things are going. This uses that PSMA technology that we were talking about earlier on the scans. And so this is for men that have metastatic castrate-resistant prostate cancer. Most studies you have to have already had chemo in order to be able to be a candidate for this. And so you essentially, again, it's a radioisotope that's injected into you, and targets the PSMA protein, which is on prostate cancer cells, but it works for both bony and soft tissue metastases. So this is something that a lot of us are excited about. It's the way it works is that when you get a new technology, it usually gets added in at the end. Okay. But a lot of these technologies, as we get more experience with it, it's able to get moved up into the algorithm, and we can use it sooner and sooner on patients. But this whole concept of having the precision or targeted therapy where we're not, carpet bombing a patient, we're really just trying to nail the actual cancer cells, is where all of oncology is going. That'll make the treatments less toxic, potentially more tolerable and more effective. Okay. Now, one of the things that when you go for these treatments, it's important to know, well, what am I going to get out of it? Because I've already kind of gone through some of these things. They all potentially have some side effects. They all have some risks associated with it. But the typical median survival for all these different things is 4 months or greater. And you may say that's not a lot, but if you add them all up, it's adding years on the patient's lives. So we've come a long way, still a long way to go with advanced prostate cancer. But I think this kind of technology and the growth of it is going to be very helpful going forward. So I know I've given a ton of information, but hopefully this at least gives you kind of the framework by which, when you hear these things, you kind of know where they